Hi everyone, and welcome to this panel discussion on communicating your diagnosis, your care team, and beyond. My name is Alyssa Creamer, and I'm the Senior Director of Education and Community Services at the Immune Deficiency Foundation, and I will be your moderator for this panel. Thank you to our generous sponsors for their support of our educational programming. This session is supported by CSL Behring. Please note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. And here at IDF, we offer a wide array of educational presentations, including presentations developed by healthcare and life management professionals who are invited to serve as presenters. The views and opinions expressed by guest speakers do not necessarily reflect the views and opinions of IDF. Now today I'm joined by a panel of very highly regarded clinicians who will share insight into effective ways to communicate your diagnosis with your care team, from a care team. Joining us today are Dr. Theo Heller, Chief of the Translational Hepatology Section at the National Institutes of Health, Dr. Jennifer Puck, Professor of Pediatrics and Immunology at the University of California, San Francisco, and Director of the UCSF Jeffrey Modell Diagnostic Center for Primary Immunodeficiencies, and finally, Dr. Beth Younger, Nurse Practitioner and Program Coordinator in the Division of Pediatric Allergy, Immunology, and Rheumatology at the Johns Hopkins Hospital and Assistant Professor of Pediatrics at the Johns Hopkins University School of Medicine. So welcome, all three of you. All right, so today we are here to learn some strategies and tips on how to effectively communicate with your team of clinicians, including how to have the necessary and sometimes hard and challenging conversations surrounding your PI diagnosis. So let's jump in, and I really want to start with just a quick show of hands from the audience. How many of you are diagnosed with PI and see an immunologist, but also have a co-occurring condition or a comorbidity and see just one other specialist? All right. How many see 2 or 3 other specialists? All right. Do you see 4 or 5 specialists? Oh my goodness. All right. You're spending a lot of time in a doctor's office. And anyone more than 5? Wow. Okay. So I think I understand and see kind of why everyone is here, that coordinating care amongst care teams is probably really challenging, and you're here to hopefully learn some tips. So thank you for being here, especially with a rare disease like PI. So I'd like to set the scenes for some of our clinicians with a common question that we hear at IDF from those navigating PI and other co-occurring conditions, is that they may see an immunologist who's very knowledgeable in helping them navigate PI. However, they have a GI, a sinus, a dental, and insert other condition here. And their specialist is either just very naive about PI, which is very common, like providers specialize in something for a reason. They're not experts in everything. So sometimes you're just naive and need a little bit of help or information. And then there's others who just have no interest in learning about PI, which is maybe just a little less understandable. So using this as our framework, we're going to focus our conversation today around 2 themes. So what's in the realm of a responsibility for a clinician during an appointment as part of your care team, and then maybe what's in the realm of responsibility as you as the patient in relaying information to your care team. And then how these can be kind of separate, but also a dual responsibility or dual advocacy opportunity. So in the realm of responsibility for clinicians, here on this stage is a group of people who are fierce champions of the PI and rare disease community. However, we know, and as we just saw in the audience, that your patients may work with a wide variety and multitude of healthcare professionals in and outside of your own office. So what are some common barriers you face establishing integrated care with a patient's full care team? Dr. Puck, let's start with you.
Okay.
Yeah.
Well, I think we could learn a lot from the audience about this, from their own personal experience, but we all know that in the United States, our medical care system is very fragmented. And so we have to just find pieces of it wherever we can. We also know that there are big distances that people may have to travel. Most individuals with PI don't live near a major center, And so it's extremely difficult for them to have all of the specialists who might be ideal to work on their condition if they're far away. And then I think we do have a duty as clinicians to communicate with the specialists that our patients see and try to find the right specialist for the right patient, because that's certainly a partnership that has to be established, and it's not something you can count on, and that one doctor may be just fine for certain types of patient and not good for others. And then, of course, one of the elephants in the room is the insurance and authorization process, which can be a huge barrier to seeing the right specialist.
Yeah, thank you. Dr. Heller, do you have anything to add, especially knowing that you work at a place like NIH where people come from all over specifically to come and see you? So talking about like the distance and what are some barriers you see related to that?
First, I'd like to say how grateful I am to be here. And I think this is a very important topic, and I'm thankful for the invitation. It's been very inspiring and humbling, even more than practice, to see so many people who are so serious about this. I think at the NIH we have a number of unique and then the same as everyone else problems. The first thing that I struggle with is that we don't have a universal medical record. So in a lot of the Maryland, DC area, people use Epic, and if consent is given, you can read the patient's records in Epic. Getting access to the patient's records is a huge barrier for us. The second thing is we're in many ways the ultimate ivory tower, and when patients come to us, the 1% is the 100%, which is good for the patient, but it's not always good for the referring physician. And so communicating with the referring physician is a real problem for many reasons, not because I think they know better, but often because they're a little bit scared or a little bit intimidated. And it's so important to build those relationships over time and for people to understand that we have the same shared interest, the patient. And we both want the patient to get better. And we have to both be open and learn from the patients and from each other. And once that is achieved, I think all barriers fall away, and then it's easy to communicate.
Yeah, so how can our audience members play an active role in ensuring that critical connection of communication between their clinician and their referring office? Dr. Younger, do you have any insight here? Or wisdom?
Wisdom, oh my goodness, that puts the pressure on. To tie together what Jennifer and Theo said, I think it's an absolute collaboratory process. My mantra for my patients is, I work for you, you don't work for me. But I do expect you to bring me some things. If you want me to communicate with a group of multiple subspecialists, I need to know who those people are. And if you've been to see multiple people, I need to know about that. If you've been to an urgent care on Broadway and 3rd on Tuesday night, but they were closed on the weekend, so you went to another one halfway across town, and all of a sudden you've been to 3 urgent cares, and then you get in to see your regular doctor, that information is critically important. And I think that it's incumbent upon you as people for whom we care and your care providers to make sure that that communication absolutely takes place and we're all on the proverbial same page. And my patients know that I want to know everything. I don't have time in 45 minutes to know everything, but they know what's important. And they communicate what's important so that we can make appropriate decisions together and appropriate treatment plans together. And together is the operative word.
I like that, thank you. So thinking about those who see a multitude of doctors, especially within the same institution, or even at a different institution? Is it common for a provider to consult with an outside specialist, either at another facility or within the same system? And I know patients move away all the time. As Dr. Puck said, people live far away from the doctor that they may see. So Dr. Puck, I think I kind of know your viewpoint on this based from all your work with SCID patients, but is it common, will you call somebody's doctor if they go somewhere else, or if they move away, will you talk to them about their care?
Well, I think SCID is a good example of a very rare condition. Most doctors will never see a case in a whole lifetime of their practice. So we know that we're going to be sending our patients back to home where somebody is going to have to learn about SCID. And so I think our families have to be educators. They have to teach the local providers, this is my child and this is our problem. And then, so that teamwork has to be there from the very start. And of course, something very specialized like hematopoietic cell transplant or gene therapy that happens in a tertiary center, it's very unlikely that the people treated there are going to live close by enough to get all of their care there. So they will go back to wherever they live, and we will have to communicate with the local providers. And we start out just, I think, as you said, we have to educate them, and then we have to tell them that we have to hear from them when things are happening back home, and that two-way communication is essential.
To tag onto that, I just got a SCID patient in Baltimore that Jennifer referred to me from California. And the patient came, and I had nothing. The young lady is 19, so I knew she'd been transplanted because obviously she was no longer having active issues with SCID, but she had a variety of other problems. And I literally get a phone call out of the blue that, we need to transfer her care, and I was clueless. And I was shocked because Jennifer and I know each other. And I was like, what? You were sending me a patient and you didn't even drop me an email? I was floored.
No, that's somebody I don't know who's a East Coast
Popcorn, popcorn.
who needs an
this-
East Coast doctor.
But this is a problem. I mean, this is exactly what we encounter all the time. I mean, and I dropped Jennifer an email, and she said, oh yeah, blah, blah, blah. And I got an email back about this young lady, and 2 days later, I got a fax from her office coordinator of records on this young lady. So now, I know, it worked. But so now, I'm scheduled to see this young lady and figure out what it is I can do to help her. But this happens all the time, and this was 3,000 miles apart. And fortunately, the immunology world is a little bit tight. Most everybody knows everybody else. So we do pick up the phone, or we do drop an email, and we say, so listen, what's in my office right this minute? And they said that you said. Really? Not quite. But it does work, and it works if everybody knows to whom we should speak and what the questions are and how to seek the answers to what those questions are.
Thank you for that addition, Dr. Younger. Very timely. All right. It was. It's perfect. It's almost like they knew that this session was happening, and
Who knew that they knew?
Who knew? Who knew? So my next thought is for both Dr. Heller and Dr. Younger, and knowing that you both work at separate institutions but in the same state. And I know you talked a little bit about EPIC and the transfer of information, but because you're in the same state, do you guys interface frequently? Is that something that happens often between the two of you even, or just NIH and Maryland? Is it more common for there to be coordination within states versus across major state lines, as Dr. Puck was just sharing?
I don't think the state is the issue. And both institutions, both Hopkins and the NIH, are sort of unique, I think, in that both have a certain amount of depth in this field and in this area. So we have immunologists, we have infectious disease physicians, we have dentists, we have the whole package. So it's less likely, it's more likely that we're going to be referred to someone from Spider Earth, Nebraska, and it's more likely that I'm going to interface with someone who has no understanding of what I do or where I am, and thinks I work for the government and I sit in, you know, fraud, waste, and abuse, as we all know. So that's more the challenge than in Maryland. We do have some patients in common, and every now and again we'll ask Hopkins people what they think about a patient we're following, or recently Dr. Letterman reached out to us about a patient, a 3-year-old. So we do have some cross-reactivity, but I would say it's more with the referring teams than with the institutions.
Yeah, I agree with Theo. It really has nothing to do with the state.
Right.
It really depends. I don't mean to sound facetious, but the immunology world really is sort of incestuous, and everybody knows everybody else. And your attending was my fellow at one point in time, or my fellow has moved on, or people know each other. So it's easy because it's a small community. It's a little bit different than if you've ever gone to the American Lung Association conference. It's 10 times the size of this because the number of pulmonologists out there are, dwarf the number of immunologists. So we're all if I have a question about a specific disease, I know the person to call about that specific disease, whether that person is in Washington State or Texas or wherever. So as I said, the collaboration cross-country, even internationally, is kind of unique in our subspecialty.
Yeah, although I would say the one exception to that is public health programs like newborn screening, or in some states there are differences in coverage of state health assistance programs for different conditions. So I think it does, in some instances, pay to know what's going on in your own state. And the Immune Deficiency Foundation was very instrumental in getting states to adopt newborn screening for SCID state by state by state. So all of you who live in different states were, stepped up and talked to your local public health providers, the public health department, and even legislatures to get that to happen. So I think there is something to be said for paying attention to what's going on in your state.
Right. Thank you all for that. All right, so I know all three of you work as part of an interdisciplinary team of various specialties, various different types of practitioners, from physicians, nurse practitioners, nurses, physicians associates, and so on. And while I know a team perspective can be probably really helpful for all of you in a various office setting, it can kind of be confusing or maybe stressful for maybe those in the audience who just want to see their doctor or their nurse practitioner, whomever there is. So do you have any insight into making some of these relationships when you have to see a whole team before you get to the doctor a little easier for the patient? Is there any good insight into that?
So again, I think I work in a particularly privileged environment. We have a multidisciplinary clinic. We meet with the immunologists every Wednesday afternoon at 4:30. We have a planning meeting where we discuss all the patients coming in. We have another meeting where we discuss patients we've seen. We bring in each specialty on Zoom or in person, and we sit around a desk. So I think that's an incredible privilege. I think that's very unique, particularly because we're free of the insurance issues and the RVU issues and the time constraint issues. It allows us that. But in a different setting, I think it's really important to build that team around you. It's not always possible for you to have an institution where you have all the expertise. Not all of you are seen at our institutions. That means that you have to create that team around you. You have to create some sort of secure way of messaging everybody who sees you is involved or needs to know. I think your point about making sure that the urgent care visits are known and all those things are so important. It extends beyond the immediate team. Teamwork really makes the dream work. And teamwork really ensures that patients get best care. The team extends to family, it extends to having people who know you well, it extends to this setting, to community, but your healthcare team is the core, and that has to be built.
Great, thank you. All right, so as That was a little bit of what is the responsibility of the clinician, and we heard that from Dr. Younger's perspective and Dr. Puck and Dr. Heller that they have no way or no reason to hesitate to pick up the phone or pick up an email and shoot one across the country to the other. That's not, I guess, always the case, as Dr. Heller was speaking a little bit to just now about maybe some of those professionals that you see that aren't at the large institutions and maybe aren't necessarily willing to just jump in and call Dr. Jennifer Puck one day on the phone to talk to her about a SCID patient that's being transferred to their care. So we're going to transition a little bit to talk about some of the responsibility of the patient or the caregiver who's overseeing the care of maybe a child and whatnot, and what are some of the things you can do as a patient to kind of help those relationships and help that communication get along or continue to move along, because as Dr. Heller said, teamwork does make the dream work, and you are a very important component of that team. So thinking about responsibility of the patients, and we will hear a lot more of this tomorrow during one of our main sessions with Dr. Nicole Rochester. We know that the time in a clinician's office, the amount of time you get with a patient is very, very short and can be often fast-paced. So when someone in our audience needs to establish care with a new specialist, what should they be doing to ensure that this new clinician can account for their primary immunodeficiency in their appointment? What is helpful for them to bring to say that might not be a part of the medical record that is easily transferred? And I was going to start with Dr. Heller because he's our non-immunologist on the panel. So what is helpful for you to know when someone with a PI shows up in your office for the first time?
The time is limited. When I was a medical student, one of the most important lessons I learned was I was sitting in an outpatient clinic and a patient came in with an ingrown toenail. Turned out he was in heart failure. I had him admitted to the cardiac unit that night and he was quite sick. Long story short, he complained about me because I didn't take care of his toenail. I went home and told everyone I saved his life. So it showed me the disconnect between what a patient thinks is important and what I might think is important. But it's important for the patient to understand that too. So there has to be a balance between the questions you want to ask and the things I feel I have to get through because they're life-threatening or critical or important. The second thing is that as a gastroenterologist, hepatologist, I love seeing images. I'm a very visual person. I want to see the endoscopy pictures. It's not always in the record. I want to see the MRIs, not the report for the MRI. And I want to look at the liver biopsy myself or the GI tissue myself. So that's a challenge to get from the referring teams. That's really difficult. But that makes such a difference. There's no way a pathologist or radiologist can describe some of the things that we'd be looking for in those biopsies or images. A regular like a routine. I'm not talking about someone who sees PIs all the time.
Right. Thank you. So if you like the scans and you want to see them, does someone just ask their referring doctor, you load that on a CD for me?
We have a list and we have release forms that we send to patients and we have them signed before they come to us. And we get the CDs shipped to us and the tissue, the actual glass slides shipped to us before they come to us.
Wow.
The important thing for patients to know is that the medical records that we keep belong to you. And legally, in every single state in this country, if you request your records, they have to be given to you. Now, they can be charged for it. An office can make you pay for X number of pages, but they belong to you, and they have to be given to you legally. And the same thing goes for X-rays, CT scans, all of those. I know at Hopkins it's very easy for patients to request that something gets dropped to a disk. We have national companies with presence in Maryland, American Radiology for one, not that I'm selling American Radiology, but that's a national company, and American Radiology will drop a study to a disk in a heartbeat. We don't see new patients without records, so we consider that a patient responsibility. If you call us and you want to see us, I will see you in a heartbeat, but I need to know what's been diagnosed, what's happened to you, especially if you're coming to me for a second opinion. I want to know what the first opinion looked like and why the first opinion was made. At one of the sessions this morning, there was a lady who asked a question that she'd been diagnosed and put on immunoglobulin therapy and moved and went to a new physician, and the new physician wouldn't put her on immunoglobulin. She was furious, and the question that ran through my head was that I wonder how the first diagnosis was made, and maybe it wasn't as good a diagnosis as it could have been, and perhaps the second doctor was correct, or vice versa. But you wouldn't know that until you saw the lab data, you saw the clinical records, the descriptions of the infections or non-infections, whatever, the description of what the problem that the patient had. And the second piece of that is what I need from patients is for you to be able to articulate what it is that you want from me. You don't walk in and introduce yourself, and I'll introduce myself. But my question will be, how can I help you today? Or what brings you here today? Or what's the question you'd like us to address? And I think those are important questions. Not only am I a provider, I'm a patient too. I have issues just like everybody else. And I go to see my physicians, and I am aware of time limits that everybody has. And my favorite expression this weekend, for whatever reason, is cut to the chase. And cutting to the chase and articulating what it is you want, what it is you're seeking, I think that's an important patient responsibility. And it maximizes your time, not just my time, but your time as well. I've never thrown anybody out of my office because they've been there too long. But I have kept patients waiting in the waiting room because I've spent time with someone who needs that time. So it's a fine line for us to balance. I think that we all walk that line and avoid trying to tick people off, because when my appointment was half an hour ago, yeah, but I spent an extra half an hour with somebody who needed it, and I will spend an extra 45 minutes with you if you need it. And that's kind of my mantra for care.
I like that. Dr. Puck, did you have more to add?
Well, I think, we've heard the records and the primary data are important, and the patient communication is important, and I would endorse both of those and say, yes, we need to have the patient take responsibility for their records, but also for letting us know what's going on in your life besides what's in the records. And sometimes it's really helpful just to write this down or keep it on your iPhone in notes that, on this date you ended up getting a prescription for an antibiotic, and then how many times a year did you actually take a course of antibiotics? And to have that information, not just, trying to remember and guess, but to actually keep track of it, that's really helpful. And then it's just also helpful to let us know what bothers you the most, what's really interfering with your life and keeping you from doing what you want to do, and then we know what to concentrate on. How can we help?
I like that suggestion of, writing things down, because you might not notice that, oh, I've been on antibiotics how many times this year, if you're not keeping track of it. And then if you see it in a notebook, you might say, oh my gosh, something's up, I should bring this up. And there's also probably no shame, and I'm gonna call myself out right now, like I have a whole script of questions that I wanna ask these guys. Like there is no shame in showing up to your doctor's appointment with a bullet list of, oh, I wanna hit this, I wanna say that, I've had this going on. Just if there's something you wanna say and you feel like you might get flustered in an appointment, there's no reason that you can't write things down. You're not being tested at all in an appointment. It's for you, so don't feel ashamed to write anything down. Continuing a little bit with this, Dr. Puck, I just wanted to make sure we maybe mention the importance of when somebody goes to a new specialist, how the importance, if they are someone who has been transplanted or even in the new advent of gene therapy, how important is it to include that in your initial discussion with them? And is that one of the first things that should come out of your mouth is, hello, I've had a bone marrow transplant?
Well, yes, and I think fortunately, many of the people who've had a bone marrow transplant are living such a normal, active life that it really isn't on their mind, and that's a wonderful achievement. But when you go to a medical provider, they do need to have that background And you remind me of a young man who had a transplant for SCID at UCSF way before I even arrived there. So this guy is an adult now. And unfortunately, he developed a kidney problem that maybe also ran in his family, for all we know. And he needed a kidney transplant. And so he went to, a urologist and a kidney transplant surgeon, and they do these sort of serial transplant matching things. And they had matched him up with donors around the country, and he never mentioned that he'd had a transplant, that his donor therefore was a perfect match for all of his blood and could have given him a kidney and would have, in a heartbeat, this sibling would have given a kidney, but he ended up getting a kidney from some unknown person who wasn't as good a match because he just, he didn't bring it up. So that's an extreme example, but that should never happen.
Yeah, fascinating. So thank you. All right, so what would you say to encourage someone, and this just happened through Ask IDF just a couple of weeks ago, and I was just talking to Dr. Younger about this. So what would you say to someone or encourage them, someone who's too nervous to ask their doctor questions in an appointment? I had someone who was newly diagnosed, was recommended to go on IG therapy, and rather than asking their doctor any questions in the appointment, left that appointment and then called IDF and had very simple general questions, just is IG therapy lifelong? Do I have to go somewhere to do it, or can I do it at home? And didn't want to bother her doctor with these questions. And I was happy to answer them, but my first thing was like, whoa. You can always ask your doctor questions. So coming from all of these wonderful clinicians, what do you say to someone who just might clam up in an appointment and doesn't want to say anything? Dr. Younger, let's start with you.
Thanks. I always get these questions. So I get that you may be nervous going to talk to your provider, but I think the first part of that has to do with establishing a therapeutic relationship, and that's a kind of a sociologic term, but it's a relationship that you benefit from, and that you feel comfortable carrying through. If you don't like the person you saw, you don't have to go back to that person sometimes. Sometimes if you're limited because there's only one person in an area, but usually there's a workaround. But I think, and I certainly understand apprehension, and I certainly understand anxiety, but I think that this is your life we're talking about, and your health, and your ability to do the things that you want to do. And I think you really need to move on from that. I know that my conversations about a diagnosis generally take about an hour, and I always know when to stop because the window shades come down. The eyes start to glaze over, and I'm like, you know what? I can say 100 more things, and not a single one of them is going to get communicated. So I send people home with written materials. I send people home with ways to communicate. And I say, this is not the beginning of the end all of your question time with me. So when you're driving home in the car and you're like, oh, beggars, I forgot to ask her, da-da-da-da. These are the 3 ways you can get a hold of me to continue the conversation. Sometimes I'll give someone a diagnosis and their spouse isn't with them. And I get the question, will you talk to my wife or my husband about this? In a heartbeat, that's what we do. We've been talking about communicating and emphasizing that it's a two-way street. But I think if you're really in that boat where you're not comfortable, it has to be beyond bothering, because I'm sorry, you're not bothering us. You are paying our bills, so we should deliver the service that you're paying for. And I hate to sound mercenary, but that's the reality. But I think it's incumbent, as I said, upon you all as patients to move beyond that anxiety and that apprehension and say, no, wait, this is the question I came to today, or these are the answers I need. And you'd be surprised, sometimes the answers are, can I do it at home? In a heartbeat. Well, that took about 10 seconds to answer that question. So how much could you be bothering me? That's the end of my soapbox.
Great.
So can I answer that as well?
Of course, yeah.
The earlier discussion also reminded me about one of my favorite patients. I have no favorites, but one of my favorites. She's an 83-year-old retired librarian, and she's really fine. But she comes to me with a typed list of all of her medicines and a typed list of everything that's happened since I last saw her, sometimes just the right amount, and a typed list of questions. And one of the things I've got her to do is to talk to some of the new patients. And as a librarian, she understands information and information curation. And having her, it's called imputed excellence, having her say it's okay to come in with this and it's okay to come in with questions has been very helpful. As a physician, I have a responsibility also to sense the anxiety. I have experience seeing patients who are anxious, as do all of us, and so we learn to recognize it. And we say this is a safe zone without using those words. We say that with our body language and with our words. And then we also say it's a safe zone because we ask them questions and we raise topics that might be uncomfortable. I learned this from a stoma therapist. She used to walk into the room and say to the patient, let's talk about sex. I wanted the floor to open up, and I wanted to disappear, but she would just be very frank and direct. And I learned from her that this is another way to deal with it. And the last thing I would say is that coming to places like this and empowering yourself and learning about advocacy and becoming your own advocate because, as you said, your life depends on it, is such an important concept.
Thank you.
Yeah, I would also just say that when we communicate with families, especially when you're giving a new diagnosis, you can't give the whole thing. You can't dump the whole thing at once and expect that to be received or that to be it. And in particular, when we start talking about gene mutations and genetics and genetic testing, that really is its own conversation that has to take place at a different time. And so, you know, the very obvious example is a brand new baby with SCID diagnosed by newborn screening, and the family's coming in shock, thinking, you know, this baby looks normal and everything looks fine, and you're telling us it's not fine. So you're turning our world upside down. Well, that's a lot to absorb. And then to start talking about this gene and mutations and inheritance and offspring and reproductive risk, that conversation needs to be later. And so we need to modulate sort of the doses of information, just the way we do the doses of medicine that we prescribe.
Thank you. All right, being mindful of time, can each of you leave the audience with maybe an anecdote or a story or any final pearls of wisdom where the clinician and the patient caregiver kind of work together to have a better outcome, better health outcomes pertaining to a PI diagnosis and their continuing care? Do any of you have any great success stories? I know we've heard a few sprinkled in here and there, but also being mindful of our time. We've got 7 minutes left.
So I can start with not necessarily a diagnosis, but a treatment. I have 600 patients on immunoglobulin replacement therapy. 599 of them are very happy with their treatment, but there's that one. And I work extensively with my patients on therapy to make their therapy look the way they want it to look. And when I teach them, I say, you know, I have to tell you the variables are not unlimited, but they really are more than you can begin to count. I can change, tell me what this therapy looks like for you. And I actually had my greatest success story is a late teenage boy that I sent off to college. And he was playing ice hockey for a Division I NCAA team. So he was a really good ice hockey player. And he would be on the ice with the team at 4:30 in the morning. He'd be in the weight room at 5:30 in the morning. There was team breakfast at 6:30 in the morning. And then 7:30 classes started across campus. And he'd fit in a few classes here and there before he jumped on a plane to go to the hockey game of the week. Well, in 8 semesters of college, that young man changed his infusion regimen 5 separate times because every semester his life was going to look a little different. And now he's all graduated and all grown up, and he's a policeman at a county near Baltimore, Maryland. So he's still changing things because he's doing shift work, and sometimes he's doing a desk job, sometimes he's in the car patrolling Route 70 looking for me speeding. Other times he's doing other things, but he totally took control, and we worked together to give him that control and to give him that comfort. And that's what I really do with my 600 infusion patients and my other immunodeficient patients as well. It's absolutely a partnership. It's absolutely a collaboration. And if you're ticked at me about something, you got to tell me you are. So, I'm not sure I like that answer or the way you frame that. I'm okay. What bothered you, and how can we fix it? And it's always a we. And I'm fortunate at Hopkins to have a professional partner with whom I'm sort of joined at the hip. We call ourselves our professional spouses. And we address every patient together. And our joke is that our patients are lucky to have a mama and a daddy, and it has nothing to do with gender, but everything to do with perspective. I'm a nurse practitioner, he's a physician. So we think about things differently, and something will come up, and my partner will say, da-da-da-da, and I'll be like, oh, beggars, I never would have thought of that. And vice versa. I'll say, oh, this is what we should do. And he's like, in 1,000 years, I would never have thought about that, Beth. But we work together to provide the care that our people need. And as I said, it absolutely is a two-way street, and we depend on our patients as much as they depend on us. And hopefully it works. I think most of my patients are, as I said, pretty happy.
Thank you. Dr. Pucker, Dr. Heller, any pearls of wisdom, success stories?
I have a brief story, but not about myself. I work with an immunologist called Jenna Bergeson, who's really fantastic. She's relatively young, and she had a patient who developed GI issues in a small town, and the gastroenterologist was preparing to go and do endoscopy for the 5th time. And kind of that's the definition of insanity, doing the same thing over and over again without a change. So she called the physician. She called him. It's the NIH calling. He ran to the bathroom, locked himself in, of course, and Jenna got him out of the bathroom, spoke him off the ledge, explained to him what her concerns were, and in the end, made sure the patient got appropriate care, which wasn't another endoscopy. So someone who's really an advocate, the patient saying, why am I having this the 5th time? Why, if 4 didn't work, is 5 going to make a difference? Calling someone else, Dr. Bergeson caring enough to then call the physician and say, listen, as a team, not because I think you're terrible, I understand you're struggling and trying to help the patient, but as a team, we can do better. And that, I think, is what advocacy is about.
Thank you. Thank you. All right. All right. Well, thank you to the 3 of you for your honesty and your engagement on this topic. I think you've left, well, certainly me, and I hope everyone in the audience, with a lot to think about as they go back into their communities when they leave Chicago this weekend and go off to their medical appointments and their various care teams. And I think the biggest thing we learned is that communication is a two-way street. It's your doctor and your clinician has a role, and you as a patient has a role, and you guys can work together and hopefully give you some bravery in that these are just regular people here who have an expertise and are willing to help. You just have to bring the questions and be brave and come with your list to ask them. So I want to leave everyone with just a couple of resources that are available through IDF on this topic, being your own health general manager on your journey with PI, which was a webinar, some resources on explaining your diagnosis to others, and we also have I am immunocompromised cards in both English and Spanish that are also really beneficial as you go into your appointments or find yourself in any sort of emergency situation. And I also want to encourage everyone to join one of the sessions tomorrow at 10:15. It's about practicing some of these lessons with having conversations with your care team in a medical appointment. So if you'd like to practice what we learned a little bit today, I encourage you to join that session tomorrow. So I'm sorry to say that our time together has come to an end, but thank you very much, Drs. Heller, Puck, and Younger, for sharing your wisdom with everyone. I know you are all PI champions, and I know I was honored to hear from you and hear your perspective about how to be a successful communicator on a care team, and I hope everyone walks away today feeling a little more emboldened and empowered to do so as they go off to their next medical appointment. So thank you again. And everyone, please enjoy the rest of the conference. We're not done yet. I know Jory mentioned earlier, maybe once, twice, 5 times, that there's maybe a documentary premiering tonight. I don't know, maybe. But we hope to see you for dinner later, and also the sessions that remain for today. And if you, again, have questions, you can get help from Ask IDF, or you can participate in any of our Get Connected groups for any necessary peer support. And you can always find us online. So thank you again, all 3 of you.